Yes, sir.
Yeah. Good afternoon, everyone. Uh, like previous program, today we are here with another episode of Odyssey of Teachers, a new initiative by Foxy ICOG under the leadership of Dr. Parag Binewala, our ICOG chairperson, and Dr. Sunita Tendulwarkar, President Foxy. And this program is the second module in a series of online learning methods, and this is an academic program for the faculty. This is to sensitize faculty with the newer teaching learning methods under the concept of competency based postgraduate training program of NMC. We have conducted the first module on small group discussion teaching methodology in May 2025. And today we are here to depict two newer teaching methods, that is case-based learning and practical skill-based learning. So today we will be demonstrating these two methods of learning. As you know, case-based learning is a teaching method that guides students to analyze cases by referring to real or well-designated clinical cases. This approach promotes active learning and helps in the development of critical thinking and analysis in the students. It fosters autonomous learning and enhances the applications as well as interpretation of basic theory knowledge. As students apply these problem-solving skills in real-life situations, and teacher act as a facilitator. Actually, in competency based learning, teacher is the facilitator and students learn by discussion and by interaction among themselves. So that is the main purpose of these new teaching learning methods. And similarly, in practical skill based learning, students actively discuss and learn the topic with hands-on training under the guidance of facilitator instead of learning a simply a didactic lectures. So in today's program, we have two topics. A topic pregnancy by student of, say, GS Medical College, Mumbai, under Professor Padmaja Samant, and ovarian carcinoma by a student of Bharati Vidyapeeth, Pune, under Professor Girja Wagh. And for practical skill-based learning, we will be demonstrating the skills of CTG reading and interpretation by the student of KGMU Lucknow under Professor Amita Pandey, and labor care guide by student of MS Ramaya Medical College, Bangalore under Professor Jyoti. So student engagement is the key factor now in the competency-based learning, and it promotes interaction and it enhances attention span also. So ongoing faculty commitment and development remains essential for cultivation on optimum learning environment. And I hope in today's program, there will be a lot of exchange of knowledge and information, and you will enjoy and benefit from these teaching learning methods. And we will all will learn from each other how to go about in case-based and skill-based learning methods when we are interacting with our students. So before we proceed now, I request Dr. Parag Binewala sir to say few words, as this is we are doing the program under his leadership, and this year we have started this program.
Thank you, Dr. Ashok. Good afternoon, all. I bring greetings from ICOG, and it's indeed a pleasure to address the audience today on the Module 2 of Odyssey of Teachers. This was an attempt to reach out to smaller professors from smaller societies or smaller places who are not well versed with the NMC norms of new teaching modalities. I must appreciate the efforts put in by the conveners, Dr. Ashok Kumar, the Vice Chair of ICOG, and Dr. Vidya Thobi, the Governing Council member of ICOG, ably assisted by a very young, dynamic Dr. Vandana Agarwal, who are the persons behind this program. Thank you all the faculty today, all the professors, Dr. Padmaja Samant, our own Dr. Sheila Mane, the chairman-elect, Dr. Arup Kumar Mazi, Dr. Amita Pandey, Dr. Sangeeta Rai, Dr. Girija Wagh, Dr. Pradeep Kumar Saha, Dr. Jyoti GS, and Dr. C. Nirmala. I'm sure this is going to be a great learning experience for all of us, as well as students and the teachers from remote areas of our country. I must put on record sincere appreciation to Team MCure Zenex, who are our academic partners and who have helped us in recording all the sessions, because we wanted the scenarios to be recorded from the medical colleges. My best wishes for the program and happy learning to everyone. Thank you very much for joining today.
Thank you, Dr. Parag Benewala. And let me inform all of you that the format of today's module will be, uh, we have a institute who are very much prominent for uh, new learning methods. And these institute will present, they have recorded, and we will be presenting the video recording of the demonstration of 15 or 18 minutes. And after that, we have experts. They will discuss and they will highlight the important points of the techniques. And we have Dr. Sheila Mane as an expert, then Dr. Arup Majhi, Dr. Sangeeta Roy, and Dr. Pradeep Kumar Shah, and Dr. Nirmala. These are the experts for today's different sessions. And I have with me again via chairperson-elect Dr. Sheila Mane, Dr. Vidya Thobi, and Dr. Vandana Agarwal from ICOG to welcome you all. And we have Dr. Lakshmi Srikhande, Madam, also a past chairperson of the ICOG, to encourage us with all our programs. And before I proceed further, I request Dr. Sheila Varne, Madam, to say a few words.
I'm here, Dr. Ashok.
Yes. So, Madam, please address at the start of the program.
Okay. Yeah. I would like to congratulate Dr. Parag and Dr. Ashok for starting this teaching module particularly. And I think it will be very useful for the teachers. Particularly, I know that medical college teachers are getting trained regularly. But the teachers, those who are with the DNB institutes, may not have that much of exposure because they are not into the medical education. So these programs will definitely help not only the teachers but also the students, and it will be interesting for the students. I have attended the first program in Delhi, and I think it is really very educative because here it is only not one way. It is most of the topic is presented by the students and they have read the subject thoroughly. So the discussion, whatever happens, is also fruitful. And the another team also tells them that what is remaining like that, which happened in the first. So we are doing the second module today. And I wish all the best for this program. And thank you for giving me the opportunity to be a part of it. Thank you.
Thank you, Madam. Now I request my co-convener, Dr. Vidya Thobi, again a teacher from South, and she is here to continue the program. Thank you, Madam.
Thank you and welcome to this Odyssey of Teachers, that is a series of online learning methods. So we are well versed with various teaching modalities, and now the focus is on the students. So student based learning is what we intend to, and as a teacher we always wish that the students also take part of these interactive sessions. And I'm immensely thankful to Dr. Parag Biniwale, Dr. Sheila Mane, Dr. Sarita Bhalera, all ICOG faculties, and those faculties who have joined today also. I am immensely thankful to them. They are all eminent teachers, and we always talk to them about various methodology. And now this demonstration is just have recorded, but actually it should be implemented in your different colleges or DNB institute. You can implement how it is shown here. So first I must thank Dr. Vandana Agarwal, who is actually a backbone of this Odyssey of Teachers. She has communicated with the people, she has assisted them for recording, and the students who have joined from various medical colleges, I must thank them also. Now, the case-based learning, that is what we are going to do first. And the topic is, we all know about the ectopic pregnancy, but how the students take this, how they discuss, let us see. This is a recorded one, but the expert comments are there again by Dr. Sheila Mane and also Dr. Arup Marji sir from Bolpur. So can I have Dr. Padmaja Samant CV to introduce to the those delegates who have joined? Vandana, can you display
Yes.
the series?
They are sharing the screen now.
So Dr. Padmaja Sawant, she is head of the department of SEC GS Medical College, Mumbai. And the demonstrators are Dr. Chinmay Basavagada, Dr. Vrushali Patil, Dr. Mridula Kulkarni, Dr. Tehsin Naz, Dr. Animesh Kaushal, Dr. Shrikant Reddy, Dr. Shamama Khan, Dr. Shruti Deshpande, Dr. Yashoda Ladia, Dr. Nisha Yadav, and Dr. Madhulika Kotyal. So after this short introduction, I request Dr. Vandana to just put a video
Yes, ma'am.
on the ectopic pregnancy.
Yes, madam. Backend team, please share the video.
Yes,
Yeah.
ma'am. So any queries you can put in the chat box, those delegates who have joined. And our experts are there, as well as Dr. Padmaja Samant is also there online to discuss and to answer these queries.
Okay. So, good afternoon, all. Today we have gathered here to do a discussion on a case of ectopic pregnancy. Ectopic pregnancy is a not so rare emergency that you all see, and you all see that in variety of presentations. There can be a sudden acute presentation of an ectopic who is hemodynamically unstable, and there can be something like a chronic ectopic pregnancy who comes with pain in abdomen and there is a needle-defined mass, and then we open her as a working diagnosis of either chronic unruptured ectopic, or we can maybe endometriosis or something. In between we had a case of endometrioma which we thought, and it turned out to be an ectopic pregnancy. So Yashoda here has prepared a case. She is going to put forth the history of the patient in front of you. Yes, Yashoda?
There was a 30-year-old female. She was a primigravida, married since 3 years. She complains of 2 months of amenorrhea. She has conceived on ovulation induction drugs. She came to the emergency with complaints of lower abdominal pain since the last 4 days and history of vaginal spotting since the last 2 hours. She had no other significant medical or surgical comorbidities. On examination, general condition was fair. Patient was afebrile. Pulse was 92 beats per minute. BP was 120/70 millimeters of mercury. Cardiovascular and respiratory system revealed no abnormalities. Per abdominally, there was right iliac fossa tenderness. On per speculum examination, cervix and vagina were healthy. Mild spotting was present. On per vaginal examination, the uterus was found to be of 6 weeks size. Right fornicial fullness was present and other fornices were free and non-tender.
Okay. So now, how should we start investigating this patient, Vrushali?
First, confirm the pregnancy by a urine pregnancy test, and this patient was stable, so we got a scan done. Simultaneously assigned her serum beta HCG levels. On the scan, there was a right adnexal mass with G-sac-like structure of around 3.5 centimeter, features suggestive of unruptured right ectopic pregnancy.
Okay. So if this patient were not hemodynamically stable, what would you do?
And we have taken her for exploration.
There is a small role for colpopuncture in such a patient where you want to establish the diagnosis. If the pregnancy test is positive and patient has fainted, she has a tender abdomen, mild distension, she's extremely pale, tachycardic, etc., there is still a role of colpopuncture which can give us non-clotting blood in the peritoneal cavity. Why does the blood not clot?
And it lacks the clotting factors.
And in which case, yes, and in which case blood can still clot?
If there is a massive hemoperitoneum, in that case, the blood might clot.
There might be still clots in the paracolicators, etc. when you do a laparotomy. Okay. So after that, what would we like to do?
Ma'am, in this case, we have already sent the beta HCG levels. So beta HCG levels of more than 2000 million international units per ml. At this levels, the GSAC should be visible on the intrauterine cavity on the transvaginal ultrasound. If it is not visible, in this case, the beta HCG values have come out 3000 milli international units per ml. If the values come out more than 2000 milli international units per ml, that is the discriminatory zone above which intrauterine gestational sac should be visible. If it is not visible, it has to give rise to the suspicion of an ectopic pregnancy. Beta HCG values otherwise.
On which scan?
On a transvaginal ultrasound.
And then transabdominal?
For more than levels of 6000 milli international units per ml.
Okay. There should be a sac present. Okay.
Beta HCG otherwise also helps us to monitor role after to choose the therapy if we can opt for a medical management or a surgical management.
So what is the cutoff?
5,000 units, less than 5,000 milli international units per ml. We can consider medical management.
Okay. So how would you like to manage this patient, Chinmay?
Ma'am, since the patient is vitally stable and her beta HCG levels are 3000, which is less than 5000 international units per ml, and her USG scan is suggestive of a gestational sac, which is less than 3.5 centimeter, and fetal cardiac activity is absent. So these are the criteria which fit for opting or giving the patient to medical management.
How will you counsel this patient for medical management?
Yes, ma'am. So medical management, usually we give injection methotrexate. It is an anti-neoplastic drug. So it has its own side effects. So we have to counsel the patient regarding the various side effects, which could include A granulocytosis, which is detrimental and might cause infections. Second thing is, even after, despite the therapy, the patient's beta HCG levels might not get back to normal or zero, and she might require a surgical exploration. So it is not a short management option which we can provide the patient. So if the patient is having other contraindications for methotrexate therapy, which could be if the patient is a lactating mother, or she has an intrauterine gestation, or she is having an alcoholic liver disease or any other liver disease, renal diseases, or immunodeficiency disorders, or any acute pulmonary thromboembolism, in all of these conditions, we cannot give her an option of medical treatment.
So, okay. So if there is no option of medical treatment, Tehsin, what should we be doing?
Ma'am, we can proceed with surgical, we can give an option of surgical management, that is laparoscopic guided. As the patient here is hemodynamically stable, we can give her option of laparoscopic salpingostomy, as she is primigravida and desirous of future fertility. So we have to give her an option of laparoscopic salpingostomy, in which we give an anti-mesenteric border, we give a 1.5 centimeter incision and take out all the ectopic sac, and then we give a saline wash. After that, we have to repeat beta HCG level on the next day. It should the fall should be more than 50%. If it is less than 50%, we have to give a single dose of methotrexate again. And then serial beta HCG should be monitored. And if not, if the family is complete, we can give an option of laparoscopic salpingectomy. That's it. And if the patient was opting for medical management, then
what is the chance with salpingostomy? There may be retained bits of trophoblast, and what may happen in that case?
Ma'am, the risk of bleeding is more, and also a risk of infection and risk of pyosulfins and
adhesions also could be there. So what should we be doing?
In that case, salpingectomy is done.
Can we offer her something else? Is there a role of methotrexate in that patient?
Yes, ma'am. Even after that, if the beta HCG is not less than, if the fall is not more than 50%, then we have to give single dose of methotrexate.
Okay. And what about the salpingectomy patients? How do we cover the stump? Stump is something that will cause adhesions, isn't it?
Burial of stump.
So how do you do burial of stump? So there is something called as Coffey's procedure, in which the round ligament is taken around the stump of the wherever the salpingectomy is there, so that there is no adhesion of any bowel loops or omentum over there. Okay. Because still in many places, in many cases where they have not finished childbearing, there could still be a patient who wants to conceive and she cannot afford such adhesions anywhere in the peritoneal cavity. Secondly, bowel adhesions none of us can, it's something that has to be prevented. So Coffey stitch is a good idea in those cases. Okay. Do you remember there was a case of query cervical ectopic pregnancy in our unit some time ago? So can you tell us about that case?
Yes, ma'am. She was primary gravida, 8 weeks of gestation. Now had come to the casualty with profuse bleeding per vaginum. So we had a dilemma in our mind whether it was an intrauterine gestation which has dropped into the cervix, or it was a cervical pregnancy. Patient was vitally stable. So we have got a...
So how do you differentiate cervical ectopic pregnancy from an incomplete abortion?
Ma'am, one is beta HCG levels. In the abortion, beta HCG levels will be in a falling trend. And cervical ectopic...
If we are talking of one level, we cannot really decide. Incomplete abortion and cervical ectopic pregnancy, it may not really grow much if it is not viable. That is one thing. And second is the falling trend by single this thing we cannot make out. Then what are other factors?
Ma'am,
on ultrasound, what will be seen?
So in that case, ultrasound will be helpful for us. In a cervical ectopic pregnancy, the gestation sac will be seen below the level of internal os. Cardiac activity might or might not be present, and there is a sliding sign wherein gently a transducer probe is used to move the cervix.
Transvaginal transducer probe.
Transvaginal transducer probe is used.
It's moved along the cervix.
Yes, ma'am.
So in that, what it's seen?
If the gestational sac moves separately with the cervix, that means it was an intrauterine which has got
expelled, and it is in the cervix, and it might be expelled later.
Yes, ma'am. Okay. And if the gestational sac is not moving, that means it has got implanted there, more likely a cervical ectopic pregnancy.
But we must watch out for such test, because suddenly there may be profuse bleeding, and that such testing might be detrimental to patient's health. Okay. What are the... Can we talk about any other abnormal or rather rarer cases of ectopic pregnancy? How much time do we have, Madhulika? 12 minutes are over. Okay, so we have 3 minutes.
Cesarean scar.
Okay. So what is cesarean scar ectopic pregnancy?
When gestational sac is implanted at the previous cesarean scar site. So it is rare, ma'am. 1 in 2,000 pregnancies have cesarean scar ectopic.
But now with rising trend of cesarean sections, very high incidence of cesarean. So these patients may be there. So what about that? How does it present?
Ma'am, they come with complaints of pain in abdomen and sometimes spotting per vagina. Otherwise, it is when the dating scan is done ultrasonographically, it is diagnosed. Where the G-sac size is
How should this patient be managed?
Ma'am, one is medical management. Because the chance when we give them surgical option, the risk is more because it's previous scar, and we have to excise the previous scar in that cases, and also the risk of hysterectomies are more. So we can, if the family is incomplete and they are desirous of future fertility, then we can give an option of medical management where the intrasaccular injection of methotrexate is given. Even if the high beta HCG and cardiac activity is present, that we can
later on we can do a curative.
And also the investigation of choice is MRI, where we have to see the myometrial thickness. It should be more than 3 mm. So, and And next is laparoscopic guided surgical excision of the scar. And otherwise, we can proceed with hysterectomy.
Okay.
If the family is complete.
Okay. So now you talked about the cesarean scar. She talked about the cervical ectopic. Which are other two ectopics?
Ovarian and peritoneal.
Ovarian and peritoneal. Anybody knows about those two?
In abdominal ectopic, the gestational sac is found in the abdomen outside the.
So it can be primary ectopic or a secondary ectopic. Very, very rare, but. Yes.
So in this case, again, diagnosis is confirmed by a scan where the ovary and that fallopian tubes are normal, and we see a G-sac, gestational sac in the abdomen, and there is no connecting fistula between the tubes and the abdomen, or a uterus and the abdomen. While in ovarian ectopic, the G-sac is embedded in the ovary.
There are historical references to large abdominal pregnancies, which we hardly ever see now. It is not going to happen because the imaging will definitely prevent occurrence of such cases. It is only when imaging was not there that we used to have such pregnancies. So we will end today's session here. Remaining aspects of ectopic pregnancy we will discuss later on. Okay, so we would like to now summarize what ectopic pregnancy is. You can talk only about the management.
Okay. So in ectopic pregnancy, when the patient presents with ectopic pregnancy, we first do the UPT test, followed by a transvaginal scan, and we do serum beta HCG levels. So based on that, we have to give surgical management or medical management. In the case if the patient is hemodynamically stable with beta HCG less than 5,000, GSAC of less than 3.5 centimeter with fetal cardiac activity absent, in that case we can give medical management. Otherwise, if the patient is hemodynamically unstable, beta HCG is more than 5,000 and GSAC diameter is more than 3.5 centimeter and fetal cardiac activity is present, in that case we have to go for surgical management.
Okay. So I would like to know from Animesh, what is your impression of today's session?
Ma'am, this session, although brief, was very informative about the topic of ectopic pregnancy. And ma'am, even in a short period of time, we were able to touch upon different type of ectopic pregnancies.
Okay. So thank you all very much. We will end here.
Now we may invite a faculty for the feedback, madam. Video's over.
Yeah. Faculty as well as the experts, Dr. Arup Kumar Maji.
Yes.
Dr. Sheila is already there, and she has also put the query like why hysterectomy for scar ectopic. So I want answers from the faculty, those who have joined for the discussion first. Yeah.
I think scar ectopic pregnancy, it's not that always we have to do hysterectomy.
Yeah.
We do conservative, even laparoscopically as well as even if you are doing a laparotomy, we can. So that is very important, and that also decision that how deep is the invasion, depending on that. Okay, because sometimes they can just bleed. Okay, so that's okay. I mean, the way you have
Just
discussed
a demonstration,
discussion
Dr. Sheila.
from student.
Yeah, we are just demonstrating how the case-based teaching is done for the teachers who have joined or the faculty who have joined. But some of the queries, only 1 or 2 questions can be taken, what I feel. But anyway, your expert comment as experts from Dr. Arup Kumar Maji and Dr. Sheila.
Yeah, one just I would like to add one more is Like in ectopic pregnancy, there is no external bleeding. So when we are looking at the general condition of the patient, we can still talk about shock index because patient will have a hemoperitoneum. So general examination, they have mentioned about that the patient case they presented was stable, so there was no problem there. But in case if you get a patient who is in shock, okay, I mean, just for the students also, that we can peritoneum or blood loss is how much, even that can be judged. So we can include that in clinical examination. That's what one more point I would like to add.
Professor Maji, sir.
Maji,
Please,
madam.
feedback.
Thank you, Dr. Vandana, for inviting me, and all the team, Dr. Parag, also Dr. Luxi and Vidyathubi. Really, it is a wonderful case presentation by Dr. Padmaja Samanta, and the basic things actually they developed. Now, one thing is that sometimes what is the criteria of the discriminatory level? Discriminatory level, there are some controversy of the discriminatory level. It is generally accepted the 1500 beta ECG, you are expected to get the SAC. But you don't declare, if you do not get, you will have to wait at least 3500. If you do not get the SAC at that time, then you declare that probably there is a ectopic pregnancy or like that. So that is one important point. And another thing, you will have to exclude whether there are early pregnancy loss. In case of early pregnancy loss, also there may be the 3500 level or more than 2000 level. So you will have to exclude that is important point. And ectopic pregnancy is till the date, the ectopic pregnancy causes the contributor of the maternal lead as high as the 2%, 2 to 5.5%. So ruptured ectopic is sometimes come. So when the ruptured ectopic comes, diagnosis is easy. That is the triad. That is the pain and the amenorrhea, and may not be amenorrhea all cases, and pain and the bleeding. That is important. But always think ectopic. And I have seen many cases there is no amenorrhea, there is no, sometimes there is also pain abdomen. And when you do the pregnancy test by a kit and you suspecting the ectopic pregnancy, you always repeat with another kit. That is very important. But that the wrong kit, there may be wrong kit. So always you do that. And next point is the salpingostomy. When you will do the salpingostomy, that is the salpingostomy, when you do. Salpingostomy, they are always done by the laparoscopy, definitely. Salpingostomy, there are some disadvantages of salpingostomy because there is a more chance of, there is a time is, I think, there is chance of the more ectopic pregnancy. And sometimes there is a trophoblast there. So follow-up is also different. If you are sure the other contralateral tube is normal and healthy, so it is better to do the salpingectomy. That is the ideal salpingectomy. And if the pregnancy does not want child, better do the sterilization of both the tube. Because when there is a chance of ectopic pregnancy, there is an ectopic pregnancy, there is a further ectopic pregnancy. If you do salpingectomy also, is about as high as the 15%. So if you remove it, if the pregnancy does not get the child. And one thing is not discussed. Everything discussed is completed. There are two important things is discussed. The follow-up of the cases. Of the follow-up is, suppose a patient wants child. This patient was infertility, and then conical cited added. Then when you allow her to pregnancy, next how will you follow up and allow her? In fact, there is no such guideline. There are no recommendation. What is the gap between the surgery or medical treatment and the next aspect? You will have to individualize. And another thing, I do not know, there are so many experts, other experts also, that regarding the, suppose the patient is negative, whether you will prescribe immunoglobulin or not, I do not know actually, because there is some recommendation. So there is a term that is Odikontu no dosai, you can give. but there is no such recommendation following ectopic pregnancy whether there will be and you will give the immunoglobulin or not. That is it. And other thing, the post ectopic counseling is very important. You don't leave the patient. You always come to you always for follow up, because her mental trauma. And there may be some depression also, mental trauma. And usually the majority of the cases following on ectopic pregnancy, even spontaneous pregnancy may occurs. So thank you. Any other questions you can give me? This is my
Dr. Maji, Dr. Maji, can I say something?
Yes,
Yeah,
ma'am.
definitely.
Basically the discussion was supposed to be on case-based discussion as a teaching technology rather than ectopic, because otherwise ectopic itself is a wide topic and we can't finish it in 15 minutes.
Yeah, definitely.
Many things are untouched.
Excellent. They have done excellent.
No, in 15 minutes they could cover it. And what my comments are, Dr. Padmaja has involved all the students. She has made them to speak out and increase their confidence. And she has touched upon various important topics on ectopic. So in 15 minutes, we do agree that this topic can be covered. The practical skill demonstration and the case-based discussion, how to conduct these sessions, that is a demonstration by which we are just going through.
Yes.
So I am very much thankful to Dr. Padmaja, Samant, as well as the students and all the people who have joined. I am really thankful. And I am thankful to Dr. Arup Kumar Mazi and as well as Dr. Sheila Mane to bring out some important things which cannot be highlighted in short one, but we can go on discussing on ectopic for 1 hour or so. But thank you very much, sir, to bring out these important topics. And shall we move to the next session?
Yes, madam.
Because we
Thank you,
have
Dr.
extended
Poddaja,
our
for
15
fantastic
minutes.
presentation. Dr. Poddaja, starting from Chinmoy to Dr. Nisha, all of them done very good.
Very good. Congratulations. Congratulations of all the students. Now let us move to the session 2.
Madam, just 1 minute I want to highlight here.
Yes, Ashok Kumar sir.
Yes, Dr. Padmaja has very really with her team presented that how to conduct and what is case discussion based learning. But I just request the experts to carefully note down and analyze the situation. We are not interested to learn about ectopic pregnancy because that will be a separate forum and we have our program and everything. Here we have to critically analyze and highlight the component of learning method. And we have to see what are the advantages, what are the pros and cons of those methods. Those we want to bring it out in the discussion part. So, and Dr. Sheila Mane and Dr. Vidya Thopi, madam, has rightly said that we have to focus not on the ectopic pregnancy, we have to focus on the method. And this program is for teaching learning methods. And that is why it is important to understand that we focus only on teaching learning methodology. And here in case-based discussion, it is important to understand that students are discussing the case with the teacher and teacher is the facilitator. Teacher just facilitate, students have learned, and by discussing among themselves, they are trying to understand the subject. So that is the important thing in case-based discussion. Thank you very much.
Thank you very much, Dr.
Ashok.
Ashok Kumar.
Thank you.
Thank you very much. And let us move to our second session, that is practical skill-based learning. Here we welcome Dr. Amita Pandey, who is a professor, Department of Obstetrics and Gynecology, KG Medical University, and she has got many accolades to her credit. She will be talking about, discussing rather with the students about the CTG reading and interpretation, very important topic. And she will be taking into our practical skill-based discussion. I welcome the demonstrators, Dr. Shuchi Agarwal, Dr. Juhi, Dr. Manvi Garg, Dr. Aradhya Garg, Dr. Srishti, Dr. Pratibha, Dr. Deep Shikha, Dr. Monica Rai, Dr. Umang, Dr. Namita, Dr. Anshu, Dr. Jyoti, Dr. Divya, Dr. Arunima, Dr. Misbah, Dr. Guneet, Dr. Shruti, Dr. Akriti, and Dr. Anshika. Along with Dr. Amita Pandey, Dr. Professor Sangeeta Rai, who is the head of the department, IMS BHU Varanasi, also had joined in the discussion. And I welcome for this second session of practical case-based learning, that is CTG reading and interpretation. Over to you, madam, and your students. Yes.
Can we please play the video?
Shreya, please put up the video.
Yes, ma'am.
Yeah.
In this class, we will be discussing interpretation of CTG. So, in the last class, as you all know, we have read about CTG, the various methods that are used to read a CTG, interpret how you interpret it, the various guidelines, and now we will be discussing basically the cases, and we expect that you will be answering the questions. You have to read the CTG and then you have to interpret and ask the question regarding the subsequent plan of management. Just to remind you, who can tell me what are the indication of electronic fetal monitoring in labor?
Ma'am, ACOG has recommended that we can categorize indications as antepartum risk factors, intrapartum risk factors, and other risk factors.
But that is a very long list. So if you can just tell us, in India, when do we recommend electronic fetal monitoring?
As India is it's a low resource setting, we take cases like patients with cases of bad obstetrical history like stillbirth, or patients of
previous stillbirth,
neonatal death, or perinatal asphyxia, patients with high risk, high premium babies like patients of infertility treatment, and diabetic or diabetic patient or elderly gravida patient. Also, if they are patients with who have chosen epidural analgesia during her labor.
And other high risk factors like hypertensive disorders also. Okay. So these are the few indications when we do electronic fetal monitoring. Now, when you read the CTG, I hope you remember how do we read out the CTG. So, for reading the CTG, we follow this Dr. C. Brevado method of reporting. So, whenever we will show you all the cases and the subsequent CTG, you have to read it or report it using this method. And subsequently, you have to interpret the CTG as per the FIGO guideline 2015 or ACOG guideline or the NICHD 3-tiered FHR interpretation system, which is usually followed in our setup. Okay? And then you have to subsequently discuss the plan of management. Okay? So just for a ready reckoner, I hope you all remember the Dr. C. Bravado assessment of CTG or electronic fetal monitoring. You will all be expected to read the CTG using these points. Is this clear? All of you remember this? Okay. Next slide, please. The FIGO guidelines also, I hope you remember when we say that the CTG is normal, when we say it is suspicious, when we say it is pathological. Yes or no? Yes. So we will not go into the details. Next slide. We again come to the next slide. This is a chart on the basis of which you will classify your CTG. Next slide. And this is just the ACOG guideline for your ready reckoner when you will label the CTG as category 1, category 2 and category 3. Okay, so this is clear to everybody. Next slide. And this is how you have to tell the management. If it is category 1, what is to be done? If it is category 3, what is to be done? And if it falls in between, that is it is category 2, then what is to be done? Okay. So next slide.
So we come directly to the cases. So I will request Dr. Shuchi to read out the first case.
So by now you all are very well versed with CTG, and we have realized how important the CTG is in the fetal surveillance. Day in and day out, you all are using CTG in your labor room practices. So it needs more of a hands-on practice, and for that we will give you few case scenarios, and we would like you to interpret the CTG finding of those cases so that it comes into your day-to-day practice. So we begin with our first case. This was a 38-year-old primary gravida who presented to us at 37 weeks of gestation. She was admitted for induction of labor in view of she was as such was a elderly gravida and she had a cholestasis of pregnancy. So at admission her CTG was performed, and this is her CTG traced at admission. So we would like you to interpret this CTG trace, and we would also like you to suggest what you plan next based on this trace.
Ma'am, we will read the CTG on the basis of criteria using Dr. C. Brigado. First is we will define the risk of the patient. This is a high-risk patient. First of all, she is elderly gravida, and secondly, she is a known case of cholestasis, and she is having mild contractions. So we will take the patient for NST. The baseline NST.
CTG. This is the CTG that you have to read.
CTG. The baseline is 140 beats per minute, and the patient with a variability of more than 15 to 20 beats per minute. The acceleration she is having is for more than three acceleration in 10 minutes and lasting for more than 15 seconds. And there are no contraction. The overall assessment of CTG is that it is a normal CTG according to the ACOG 2010 classification. It is a category 1 CTG, and we will take the patient to the routine monitoring.
So this is how, as per C. Bravado, you will categorize the CTG. So as rightly said, this is a category 1 CTG, and we will continue with the routine monitoring of labor. So now we move on to our next case. So this was a lady, she presented to us as she was a second gravida, and she presented to us at 39 weeks of gestation. She came in active phase of labor, and she gave a history of decreased fetal movement and rupture of membrane 12 years prior. And at admission, she also had a fever of 100° Fahrenheit. So this was her CTG trace at admission. So we would like you to interpret the CTG and suggest the further course of action.
On interpreting this CTG, the defined risk factor for the patient is maternal fever of 100.9, prolonged rupture of membrane for more than 12 hours, and decreased fetal movement. With contraction.
So she had 3 risk factors.
As patient is in active phase of labor, we will monitor her CTG. On interpreting this CTG, we have 4 contractions of mild intensity of approximately 40 seconds per minute.
This is mild to moderate intensity.
Yes, ma'am. With baseline of 145 beats per minute and variability of approximately 5 to 10 beats per minute corresponding to moderate variability.
Yes.
No acceleration is seen, no deceleration is seen. On interpreting this CTG, this is categorized as category 2 CTG of ACOG 2010 classification. Now coming to the management of this patient, we will closely monitor this patient, and we will correct the reversible causes of all of the patient, making her to the left lateral position, O2 inhalation, IV fluid, and correcting maternal fever with antipyretic agents. And we will re-evaluate after 30 minutes for the next CTG reading. If it goes into a category 1, we will monitor the patient to go to continue her labor, and if it lands up into a category 3, we will take her to for the immediate delivery.
So yes, rightly said, and it was very well interpreted. Every CTG you will interpret as per the C. Bravado mnemonic. That you have to keep in mind. So moving on to our next case. So this was a primary gravida presented at 38 weeks 4 days. She came in active phase of labor, and labor was spontaneous. So for that labor pain, she requested epidural analgesia. That was given. And a few hours later, she had a spontaneous rupture of membrane and liquor was found to be meconium stain. So this was her CTG at that time. So we would like you to interpret as per C. Bravado and suggest future course of management.
So who's going to interpret? Yes, Aradhya.
The above mentioned patient is a case of high risk patient. She has two risk factors of epidural anesthesia and meconium stain liquor.
Analgesia. It is epidural analgesia.
As the patient is in labor, ma'am, we do the CTG interpretation of the patient according to Dr. C. Bravado. The patient is having more than 6 contractions in 10 minutes of moderate to good intensity. Now, she is having a baseline rate of 160 beats per minute with a variability of 5 to 10 beats per minute. The patient is having no acceleration and the patient is having
Here I will interrupt you. I think her variability is less. It is less than 10. So I would say it is not more than 5 beats per minute. Yes, then?
Reduced variability with late decelerations which are more than 3 in 10 minutes. That is repetitive late deceleration.
Yes, because here also there is a late deceleration. Here also there is a late deceleration. And here also you can see it's a late deceleration.
Now on interpreting this CTG, it is a category 3 CTG. Now in this case, we'll do the immediate intrauterine resuscitation of the baby and we'll analyze if we'll have to expedite the delivery. So analyze if we can expedite it by using the instrumental delivery, or if there is a time gap between the delivery, so we take the patient for the immediate cesarean section.
Yes, so if she is in advanced labor, she is almost fully dilated or at least 8 centimeter to 9 centimeter dilated, then you would leave her for a vaginal delivery. And if this happens in early labor, then you will take her up for a cesarean section.
Because category 3 is an omnious. It indicates acid-base imbalance to the baby. And that is why it needs immediate termination. So moving on to our last case. So I hope you will find it interesting. So this was a primary gravida. She came to us at 41 weeks of gestation and she gave a history of spontaneous rupture of membrane 36 hours earlier. And she was not, her contractions were not well established. So she was augmented with syntocinon. And she went into established labor. And her CTG at the time of admission, her paravaginal finding was 2 centimeter, 50% effaced, and station was at -2. And then at 7 a.m. after 1 hour of admission, this is her CTG trace. So we would like you to interpret the CTG trace and suggest what next.
Yes. So you are going to do it?
Yes, ma'am.
You are going to do? So let her do the first part, you take the second part. We have a lot more which is coming.
And this patient is also a high-risk patient having 3 high risks. First, she is a postnatal pregnancy. Second, she has a prolonged rupture of membrane for around 36 hours. And third, she is augmented with syntocinon. According to the Dr. C. Bravado, this CTG has 3 high risks and 4 to 5 contractions per 10 minutes of moderate to good intensity. The baseline of the CTG is around 140 beats per minute, which is normal. The patient does not have any acceleration. The deceleration are early decelerations, having the onset of contraction. The peak of the contraction is coinciding with the lowest trough of the CTG and ending with the end of contraction. There is overall impression of the CTG is that it is a category 1 CTG and we can continue with normal fetal-maternal surveillance and labor monitoring.
Yes, so you missed out one very important factor, which is shouldering. Okay, variability is also normal and you can see shouldering. You are going to tell me what is shouldering?
Yes,
so what is shouldering?
And the shouldering is the reflex tachycardia after the deceleration, which indicates normal autonomic system of the fetus to compensate for the compromise that is happening.
So that is why you can leave her for vaginal delivery and you can monitor her progress.
And what is the commonest cause for early deceleration?
Head compression.
Yes.
So after 3 hours, she was, this was her CTG trace. She was kept on continuous CTG monitoring because of that early deceleration. So her PV finding after 3 hours were that the cervix was 7 centimeter and it was fully phased and station has come down to 0. So this was her CTG trace at 10:30 a.m. So we would like you to interpret and tell what next.
So who's going to interpret? Okay.
In the current patient, we have 3 risk factors now. First is she is a postdated pregnancy. Second, she is having spontaneous rupture of membrane for more than 36 hours. That is prolonged rupture of membranes. Third is she is having we are augmenting the patient with cytosianol. So these are the 3 risk factors. Second thing we would like to interpret in this CTG are the contractions. The patient is having 6 uterine contractions in 10 minutes that are moderate to good intensity. Third thing we would like to tell is the rate, baseline rate of the CTG. The baseline rate in this CTG is around 120 beats per minute. The variability is around 15 to 20 beats per minute. And there is no acceleration. And as we can see, the patient is having around 5 decelerations in 10 minutes that are recurrent late deceleration. So the interpretation of this current CTG is that it is a category 3 CTG. And our course of action would be, we would like to reassess the patient and we would like to reassess the reversible causes of category 3 CTG. We would like to resuscitate the patient and we will keep the patient in left lateral position. We will give her oxygen inhalation. We would like to give her IV fluids and we would like to correct her hypoglycemia if it is present. And then we would like to reassess the patient in within 15 minutes.
One very important thing with which you missed out is you will stop oxytocin because she is having real good contractions. And if there is category 3 CTG, you would like to stop oxytocin. And anything else? Would you like to keep her on continuous electronic fetal monitoring till she delivers?
Yes, ma'am. As she is in active phase of labor,
active phase, and she has category 3
CTG, we would like to keep her on continuous monitoring.
So after half an hour, this was her CTG trace and she was almost fully phased. Her station was at +1 and she was around 9 centimeter. So we would like you to interpret this CTG trace.
So please switch on the mic and pull the mic close to you. Yes.
As patient is having 3 defined high risk as postdated pregnancy and spontaneous rupture of membrane for more than 36 hours and patient is augmented with cytosianol. According to C. Bravado.
No, now the risk factor has changed. We have stopped oxytocin. Now the risk factor is previous category 3 CTG. That is why you are monitoring her with EFM.
According to C. Bravado, the contractions are more than 6 contractions of moderate to good intensity. Baseline of CTG is 140 baseline, less than.
Please look carefully. Is it 140? Okay, in the left one it is 140 and subsequently it has come down. Okay.
140 of less than 5 beats per minute variability, which is poor variability, and recurrent late and variable decelerations are present. We will continue the electronic fetal monitoring for next 15 minutes and resuscitate the patient and look for forward CTG how it comes. And in next CTG.
So that is the next CTG?
Yes, ma'am.
At 12:20 p.m. What now?
In this, there are 2 contractions and baseline of the CTG is 130 with 5.
Would you like to tell something else about the contraction?
It is a good contraction, ma'am, more than 6.
Very strong contraction.
Baseline of the CTG is 130 with variability of around 5 to 10 variability, which is minimal variability, and there is prolonged deceleration present. So we will expedite the delivery by applying the ventouse or forceps.
Because the station is at +1 and she is fully dilated. So category 3 CTG demands urgent delivery. Since in this case delivery was imminent, you were suspecting that delivery will occur within half an hour or 1 hour. That is why you have kept under for prolonged under continuous CTG monitoring. Otherwise, if her labor would have been not in the active stage,
Then what?
Then what?
Yes. So I hope after all this exercise, after all these case discussions, things have become clearer. Now you know that whenever you read a CTG, what are the indications of doing a CTG? Whenever you have to read a CTG, you have to follow the Dr. C. Bravado mnemonic, and you have to interpret the CTG as per either the FIGO classification or the ACOG or the NICHD 3-tier system, and accordingly you have to manage. So this is clear to everybody? Okay, thank you so much. Ready?
So now may I please invite Dr. Ratnamala Desai ma'am to give her expert feedback on
Yes.
practical skill-based method, teaching method, not on CTG per se.
I request her to make her video on. She is an eminent teacher from SDM Medical College, was a past dean and teacher of teachers. If she is there in the audience, we would like to have her comments. Hello, Dr. Ratnamala. Yeah.
Yes, Dr. Vidya. Vidya,
Yes.
thank you very much. I'm not putting my video.
Okay, you must. Yes.
Actually,
Anyway, we need audio comments.
I'm
also.
not a little well. That's why I'm at home.
Okay. Thank you very much.
Okay, but this is a very good teaching method, very good teaching method, where each candidate was given an opportunity to interpret the CTGs and also discuss the management in such a short time, very briefly and very clearly. Very nice presentation. Thank you.
Thank you, Dr. Ratnamalai. Despite your unwell, you have joined. That shows your commitment. Thank you very much.
Thank you.
Dr. Amita Pandey, your comments on your students. The demonstration was too good. Yeah. Very simplified because CTG always our students they stuck, but the way they the demonstration and the discussion, practical skill discussions were done, they're really good. Yes.
Thank you so much for your inputs, Dr. Vidya. This is the usual method by which we teach CTG to our students. So it was very kind of you and Dr. Vandana and her team to invite us to participate in this session on different teaching methods. And our students, just before this class, we had another class where we had discussed the Dr. C. Bravado system, the indications, all the guidelines in details. So in this class, it was very easy for us to just show them the CTG, the various CTGs that we have collected over the years from our patients and ask them to interpret it and then discuss the management as per the guidelines.
Thank you very much. Thank you. Dr. Vandana, I feel that we will move to the next session that is on again a case-based learning. Case-based learning, and this time we are discussing about the ovarian carcinoma, and I invite Dr. Girija Wagh as well as Dr. Pradeep Kumar Saha for this session. Dr. Girija Wagh, we all know her very well. She is a professor and head of the Department of Obstetrics and Gynecology of Bharati Vidyapit Medical College, Pune. And she has got many professional highlights. She is a veteran gynecologist and medical consultant and expertise in patient management research as well as medical education. She has put in 34 years. She has got many leadership roles. Former VP of Foxy, Chair of Medical Disorders in Pregnancy Committee, National Mentor for Laksha and all others. So she has got many awards as well. And her areas of experts are obstetrics and gynecological care, advanced patient management, as well as she's more interested into the research in medical education. So our next expert is Dr. Pradeep Kumar Saha, who is a professor, Department of Obstetrics and Gynecology, Postgraduate Institute of Medical Education and Research, that is PGI Chandigarh, President of Association Gynecological Oncologist of India, Chandigarh chapter, and he has to his credit many publications, over more than 115 publications at national and international journal, and he's a member of editorial board and reviewer of many international journals. Special interest is preventive oncology, gynecological oncology, hypertensive disorders in pregnancy and morbidly adherent placenta, and special contribution in placenta accreta spectrum, that is developed new surgical technique to reduce hemorrhage and complication during cesarean hysterectomy for placenta accreta. And this technique has been accepted globally, and this procedure is also published. So in next time, we would definitely hear from you, Dr. Saha, and thank you for joining for this important session. And I just wanted to know the demonstrator, Dr. Khushbu Savla, Dr. Rutuja Sutta, Dr. Aditi Bawa, Dr. Pragna Agarwal, Dr. Nidhi Kelkar, and Dr. Riya Shah. So this topic of ovarian carcinoma is being discussed here, and this is a case-based discussion again. So Shreya at the back end, please play the
Can I just say at the outset?
Dr. Girija, welcome. I think she's out from the operation theater right now. You can see her. So her students, and I just introduced you. You're all positive aspects of your leadership and as well as education and research, all those things. So let us move on to this.
Thank you so much, Vidya. I was muted, so I couldn't speak. Thank you.
I know. And I can judge that you were busy in OT.
Yeah. Thank
you. Yeah. So please, over to Shreya for this ovarian carcinoma display.
So this is Dr. Girija Wagh, Professor and Head Bharati Vidyapith University Medical College, Pune. And today we are going to show you a case-based learning, the session how it is conducted ideally under the CBME. For discussion on the subject today is ovarian cancer. And here are junior residents from our department, Dr. Riya Shah, Dr. Nidhi Kelkar, Dr. Pragna Agarwal, Dr. Aditi Bawa, Dr. Rutuja Sutta, and Dr. Khushbu Savla. So we will take you through this session in the next few minutes and enact how a case-based learning is conducted normally in our institution.
My patient, Mrs. H.D., a 65-year-old woman, a resident of Fulton, Satara, farmer by occupation, coming from lower socioeconomic status, came with chief complaints of lump in lower abdomen since last 1 year and fullness in abdomen since last 1 year. Patient noticed a lump in her lower abdomen which gradually increased to the size of football. She also complains of fullness in her abdomen since last 1 year. There was dragging pain sensation on and off. She has no fever. She complains of significant weight loss over past 6 months. She was referred to Bharati Hospital for further management. She is postmenopausal since last 20 years. Her past cycles were normal and regular. Her menarche was attained at the age of 14 years. She is para 5, living 5 with all full-term normal vaginal deliveries. Tubal ligation done 35 years ago. No significant past medical and surgical history. Patient complains of reduced appetite. Her sleep, bowel, bladder habits were normal. On examination, her height was 154 centimeters and weight was 41 kgs. Her pulse being 90 beats per minute, blood pressure of 150 by 80 millimeters of mercury, pallor present, edema, icterus lymphadenopathy were absent. Her CVS and RS examination were normal. On per abdominal examination, a firm to hard mass was palpated in suprapubic region, reaching up to the size of 20 weeks gravid uterus and in left iliac fossa. It was arising from pelvis. Some cystic areas were also palpated. The surface was irregular, non-tender, and mobility was restricted. Liver and spleen were not palpable. A dull mode was heard over percussion over the mass. Shifting dullness and fluid thrill were present. Moderate ascites was present. On per speculum examination, the cervix and vagina were atrophic. On per vaginal examination, uterus was anteverted, atrophic, and firm. A hard mass with cystic lesions palpated in the left and anterior fornix. It was non-tender, it had restricted mobility, and right fornix was free. To summarize my case, a 65-year-old Paris postmenopausal woman presenting with lump in lower abdomen with ascites with significant weight loss, most likely a case of CA.
The patient here has characteristic red flag signs of being postmenopausal. She has early satiety. There's recent weight loss also present. There's characteristic abdominal distension, and there's presence of ascites. This clearly points towards ovarian malignancy.
Are there any other reasons why ascites would happen?
Ma'am, ascites can also be due to other disorders, like if there is any liver involvement or there is any peritoneal metastasis. So
chronic liver disease or cancer coming from other origin other than the ovary.
Yes.
Primary peritoneal cancer can also present with ascites.
And can an ovarian cancer be similar or a primary peritoneal pathology be similar?
And both may have a similar presentation where the patient will present with fullness in abdomen, all mass symptoms because of pressure on the abdomen.
Especially the epithelial ovarian cancers. Why? Because embryologically they have the same origin of the coelomic epithelium. So that can happen. Okay. Any other red flags or risk factors?
But differentials will be like first of all, it can be a tubo-ovarian abscess, but seeing the size of the tumor, it is like 13 into 12 into 15 centimeters. So it's very large in size. A tubo-ovarian abscess will not go to such an extent. My second differential can be a Krukenberg's tumor, but given the mass here is unilateral and Krukenberg tumor presents as a bilateral tumor.
Usually, commonly, but it sometimes can be unilateral as well.
Yes.
Yeah.
But in that case, our patient also doesn't have any GI symptoms.
Okay.
So ruling out both of these options and given history and examination, most likely our patient is having epithelial ovarian carcinoma of ovary, and it can be mucinous cyst adenocarcinoma or serous cyst adenocarcinoma.
So further on, after all this history and examination is done, we would like to move on with the investigation part. First of all, I will do the basic hematological test like the complete hemogram count, the liver function test, the renal function test, and normal serological studies. After that, all the other systemic disorders are ruled out by that examination. We can go on for tumor markers of this patient. So most commonly which is done is CA125, which is raised in mostly 80% of all epithelial ovarian cancer, but it is not specific. It can be raised in other gynecological and non-gynecological causes also. So after CA125, other tumor markers like HE4, alpha fetoprotein, LDH, CEA, CA19-9 will also do that to rule out any other sources of the cancer. HE4 will be a specific marker, and we can also calculate the Roma index for this patient by the HE4 value. After that, I'll go on with the ultrasonographic investigation, which is a trans-abdominal sonography and trans-vaginal sonography, where I would like to see the presence of any septations, presence of any loculation, presence of any papillary projections, and the main thing, presence of ascites, the amount of ascites in the abdomen. So by all these things, I would like to calculate the risk of malignancy index, which is the RMI index, which uses the ultrasound score, the menopausal status of the women, and the actual CA125 level, which I will, after that, I will like to get the risk of malignancy in that patient. So along with the RMI score, we can also calculate the Roma score, which is the risk of malignancy algorithm. With the help of CA125 and HE4, I can calculate this Roma score also. So after that, I would like to move on. I would understand, or I would like to judge the level of treatment or what level of severity the patient is.
Without that, before going the clinical and all the laboratory tests, clinically, do you think that it's essential to do a breast examination? Any specific nodes that you would want to consider?
Yes, breast examination is important in all such patients because mainly ovarian cancer is related to breast cancer, like mutation in the BRCA1 and BRCA2 genes will be associated along with ovarian cancers. Along with that, I would like to palpate various lymph nodes also, such as supraclavicular lymph nodes, also known as the Virchow's lymph node. Also, para-aortic and pelvic lymph node will also be. I'll also palpate them. And
how will you palpate the para-aortic lymph nodes? The pelvic and the para-aortic lymph nodes may not be palpable. However, inguinal lymph nodes, if palpable, then it will point towards advanced stage of the disease. That is, be directly upstage to stage 4. Pelvic and para-aortic lymph node involvement can be seen on imaging, more specifically on a contrast-enhanced CT scan.
So along with all the investigations, I would also like to do a baseline chest X-ray for this patient. As you said that the RS examination was normal, but the chest X-ray can be done to rule out any other metastasis or spread of the disease. So that I will like to rule out by doing a chest X-ray.
On chest X-ray, we will be able to see if there is any pleural effusion. Additionally, if there are cannonball metastasis to the lungs, then that will also be brought out on the chest X-ray.
And mediastinal
lymph nodes metastasis.
What is the Meigs and the pseudo-Meigs syndrome?
So, ma'am, Meigs syndrome is usually with a benign ovarian neoplasm, for example, fibroma most commonly. Along with that, there will be ascites and right-sided hydrothorax. So, the thing with Meigs syndrome is after removal of the primary tumor, it will auto-regress on its own. However, sometimes in malignant cases also these findings will be seen where it is called as pseudo-Meigs.
So probably it's believed that there are some channels which are going from the peritoneum to the pleural fluids, and that is the reason why it would happen. What is the fluid there when there is ascites?
Ma'am, in case of pseudo-Meigs syndrome, it is mainly an exudative fluid because of peritoneal implants, whereas in Meigs syndrome it is mostly a transudate.
Adding to that, we can also use IOTA simple rules to differentiate benign from malignant. It is divided, malignant points are divided.
What is the long form of IOTA?
It is
International Ovarian Tumor Association.
So it is divided from M1 to M5 and B1 to B5. Based on the characteristics that our patient represents, there is irregular solid components, there are papillary projections, and also there is presence of ascites, which points more towards malignancy than being a benign tumor.
Could you please tell us more about the USG findings in our patient?
Yes, definitely. On USG, the uterus appeared atrophic. A large complex left adnexal mass with solid and cystic components with thick septations and papillary projections with internal vascularity was noted. Left ovary was not visualized separately. The size of the mass was almost 16 by 12 by 11 centimeters. There was moderate to gross ascites as well. Her CA125 level was 480. AFP levels were 32, beta HCG 20 international units, and LDH was raised to 720. The RMI index was calculated by multiplying her USG score, which was 2, her menopausal status, which was 3, and CA125 levels, which was 480. That was sorry.
Now, were there any correlates with the IOTA? What features she mentioned? Can you just explain? Like she mentioned some features. Can you correlate with the M and the B that you were talking about?
Yes, ma'am. So M1 is the presence of irregular solid components. M2 is ascites. M3 is presence of 4 papillary projections. M4 is the irregular components.
So these were all there in the patients.
And M5 is good blood flow.
So IOTA gave us an absolute clear one. About there were certain other seromarkers which were also done, the tumor markers.
Yes.
So can you explain about those LDH and alpha fetoprotein?
So other tumor markers other than CA125 and HE4 like LDH and AFP were also done. These are mainly raised in other types of ovarian cancer such as dysgerminoma or yolk sac tumor. So in our patient particularly we'll see for if we are suspecting any epithelial ovarian cancer, we'll particularly see the CA125 and HE4 levels which were raised in our patient.
However, we did the additional tumor markers because RCOG suggests that if the mass size is more than 7 centimeter, we have to do at least 4 tumor markers. The baseline
being alpha fetoprotein, beta HCG, CA125, LDH should be done in all cases where the mass is more than 7 centimeters.
Okay.
So we did the other two markers as well, even though we had a very high suspicion of an epithelial ovarian cancer.
So what is the definitive treatment now for her?
Ma'am, basically surgical staging in our patient, considering her age and the risk factors, since we are suspecting ovarian carcinoma, we will perform a full-blown surgical staging. So the surgical staging will include a midline vertical incision. Initially, if there is ascitic fluid, we will send that for cytology. We will inspect the whole of the bowel from the cecum to the ascending colon to the transverse flexure. Additionally, the undersurface of the liver and the right hemidiaphragm. Then we will move on to the transverse colon, the splenic flexure, the spleen, the left hemidiaphragm, the descending colon. After that, we will do a thorough analysis of the small bowel. We will check for any peritoneal implants all along. And then looking at the uterus, the bilateral ovaries, and we will prefer to do a total abdominal hysterectomy with a bilateral salpingo-oophorectomy. If at any point we see any omental masses or peritoneal deposits, we will take samples from them. We will take peritoneal washings from the undersurface of the liver and the hemidiaphragm, and we would also do a pelvic and para-aortic lymph node dissection along with an infracolic omentectomy.
So to summarize, let's never take a vague symptom presenting in a postmenopausal woman lightly. Something that's presenting as simply as indigestion could have much more serious consequences.
Not only in postmenopausal women, I think in all walks of life, whenever a patient is coming to you with any kind of symptomatology, it is your bound duty to go to the bottom of it and try to find out. So thank you team, it was a wonderful presentation, and I hope the ICOG, I thank the ICOG for giving us this opportunity, and I hope we have been able to deliver what was expected of us. Thank you. Thank you. So this is Dr. Girija Wagh.
Now we please invite Dr. P.K. Saha sir to please give us feedback on the teaching method demonstrated, CBN.
Thank you so much. Good afternoon. And my special thank you, Dr. Parakshay, Dr. Ashok, Dr. Vidya, and of course, Dr. Vandana. I'm supposed to give the feedback on this case-based learning methodology on the topic ovarian cancer. The case presentation was very nicely. It was very nicely presented by the student of Bharti Vidya, which deemed University Pune under their head of the Department of Science. I must congratulate to her as well as student. They covered the topic very well, starting from the history, clinical examinations, then investigation, including tumor marker as well as CT scan, and of course the surgery. The treatment. What they have mentioned, that surgery. We understand that aim of this presentation was not to cover each and everything of the ovarian cancer in 15 minutes time, but they have done very good job. Now, focusing on the teaching methodology, which is case-based learning, it was very interactive, and what we can make out that all students actively participate. In fact, someone has mentioned that she wants to palpate the, that pelvic and para-aortic node, but on the other, on the same time, the other student, she actually corrected. She said, no, it cannot be seen. You can't palpate these nodes, but you can see on CT scan or other imaging techniques. So we can, see that Dr. Girija was very nicely facilitating the discussion and skillfully guided the discussions. And this helps the student how to apply. But what I feel that just reading a book is not enough. Just attending the seminar or that lecture, until unless they can apply their theoretical knowledge into the clinical practice. And this clinical-based learning actually it helps, and it helps a student to develop the clinical critical thinking as well as the decision-making skill. So I think that this kind of teaching methodology should be encouraged among the students, specifically postgraduates, and because this will definitely ability. This will enhance their clinical, that ability, and to apply the knowledge into the clinical practice. Thank you so much. Thank you.
Thank you, sir. Girija ma'am, if you could please speak few words.
Yeah, actually, thank you so much for giving us this wonderful opportunity, Vandana, and you've been always there supporting and helping us through the entire thing. Actually, we had also, I must tell Dr. Saha that we had also spoken about management as well as ETCOM we had included last 2 to 3 minutes, wherein we wanted to give a message as to how to speak to the patient's relatives, and it also was wonderfully picturized. But we'll put it on our YouTube channel or something so that everybody can access it from there.
It was very nicely presented.
Thank you so
Congratulations,
much,
ma'am.
sir. Thank you so much. Thank you.
Congratulations, Girija and team. It was really wonderful.
It is a lot of hard work by the students, by the way. They
Yeah,
took all the
But
efforts.
teacher also, as a facilitator, you brought the best out of the students.
Thank
I
you
must
so much.
congratulate you. Thank
No,
you.
but I am liking this new method of teaching technology, wherein you just sit and watch. Let them do the hard work.
That is a student base. Means the students are the base of learning, and we are learning a lot from the students.
And most
Reverse.
important is that you can remember the things, but we call it bedside, that whatever you read, we forget. But if you this kind of teaching, it retains. That is very, very important.
Yes, sir. Thank you.
Thank you. Thank you.
Thank you, Dr. Vandana. Thank you.
Thank you. Thank you. So let us move with the next session, that is a practical skill-based discussion on labor care guide. And now I invite Dr. Jyoti GS. Can I have display of the introduction for Jyoti? Yeah. So this is about the practical skill-based discussion on labor care guide. And it is my pleasure to introduce my dear friend, Dr. Jyoti, who is a professor, head of the Department of Obstetric Gynecology, MS Ramaiah Hospitals in Bangalore. She has got many, you can see her CV, it is full. But she was a member of my committee as well, and she's a lead assessor for the Manyata project and other projects also in Karnataka as well as at the national level. She has published many books as well as chapters, and she is also advisory committee of various committees of our Kasoga. So the next is Dr. Nirmala, who has also joined. Dr. Nirmala was there, no, Dr. Vandana?
Yes, madam. Madam is professor and head of the department at SAT Medical College, Tiruvananthapuram.
Yes. So
We'll
Dr.
start with the video.
Nirmala has also joined. So welcome Dr. Jyoti and Dr. Nirmala. And the demonstrators are Dr. Gayatri Devi, Shiva Shambhu, Dr. Urvashi, Dr. Tejaswini, Dr. Manasa, Dr. Punya, Dr. Kalyani, and Dr. Akshita. So over to Dr. Jyoti as well as Dr. Nirmala, and please display the recorded video of labor care guides.
Yes, ma'am. Thank you, madam, for your kind introduction. It was all done by Dr. Urushi and Dr. Gayatri. They worked very hard for this, and it was initially quite new, this video thing and all. We had to do a rehearsal and all. Finally, we had to settle down with only the labor care guide part, and
that is very vast, and you could do it. Yeah, we are also learning and relearning for everyone.
Something the next opportunity, I think we can do it much better.
Yes. So every point we are learning. Shreya, can you
Yes, ma'am.
play the video? Yeah.
Good afternoon, everybody. We are assembled here as part of ongoing teaching learning sessions which are made interactive as part of ICOG FOXY teaching learning initiatives. Okay. Topic for today is WHO Labor Care Guide. This has been initiated in the year 2018, and we are having an ongoing educational activity to continuously make us aware of the ways in which WHO Labor Care Guide has to be plotted. So, having a quick recap, I would like to ask Dr. Tejaswini, what was the idea in implementing Labor Care Guide?
Cervicogram, it is a component of the partogram where there is expectant dilatation of 1 centimeter per hour. But in recent studies, it has been shown that the cervical dilatation, even if it is less than 1 centimeter per hour, it is associated with the vaginal delivery with a good maternal and the fetal outcome. And also normal value of the labor care guide has stopped unnecessary intervention to occur, and also the threshold for the alerts has been timely management of labor.
Very good, Dr. Tejaswini. Thank you so much. Now I would request Dr. Mansa to answer. In what kind of a setting would you initiate labor care guide, and at what stage of labor?
Ma'am, labor care guide should be used for all women in labor at any level of any healthcare facility level, and it should be initiated when the woman enters into the active phase of labor, that first stage of labor, that is more than equal to 5 centimeter dilatation, irrespective of the parity of the woman and the membrane status of the woman.
Good afternoon, everyone. I'm Dr. Punya, and today we will be learning about the new WHO Labor Care Guide. Labor Care Guide consists of 7 sections, and we will be talking about each section in detail. Section 1 consists of the identification of the patient, which includes details, as mentioned, name, the parity, the date of admission and the time of admission, and the diagnosis at the time of admission, the rupturing of the membrane, the date and the time, and the risk factors associated, which could be obstetrical risk factors or the maternal risk factors. Also, the labor care guide provides column for mentioning at the time of entering the active stage of labor, which is 5 centimeter demarc in the labor care guide, in contrast to the WHO modified partogram, which is at 4 centimeters. And also it gives an elapsed time, that is from the time, the number of hours from the time of entry to the active stage. Section 2 consists of supportive unit care, which is a new component added in the labor care guide, which includes 4 components, which is companionship, proper oral fluids, poster, and also pain relief. So these each components are addressed with 3 other factors, which is mentioned as Y, N, and D. Y represents yes, N representing no, and D representing decline. So the column next to each of the factors represents the alert column, where each of the factor is encircled whenever, as in, for example, companionship. So next to the companionship, when it is written as no, it means that the patient does not have a companion. And it is mentioned as N and it is encircled, which means that we have to take action and a companion has to be provided for the patient for a better progress of the labor. Same continues with pain relief, fluid, and the poster. Coming to the section 3, which is about the fetal monitoring, which includes factors as mentioned here, which is baseline fetal heart rate, the deceleration of the fetal heart rate, the amniotic fluid, the caput, the molding, and the fetal position. Baseline fetal heart rate, anything less than 110 and more than 116, it has to be taken action for. And deceleration mentioned as E, L, and V, which is representative of early deceleration, which is considered to be normal. Late deceleration comes under the alert column, and we have to take action. And V represents variability. Amniotic fluid is mentioned as alert line tells there is presence of meconium and blood stain liquor. Then coming to the caput and molding, anything more than 2+, 3+ in caput and 3+ in molding is an alert. Section 4 consists of maternal monitoring, which includes her vitals, that is pulse rate, systolic blood pressure, diastolic blood pressure, the temperature monitoring, and the urine monitoring. All these factors and all the parameters in labor care guide are monitored every 4 hours. Pulse less than 60 and more than 120 is an alert. Systolic blood pressure, anything less than 80 and more than 120 is an alert. And diastolic blood pressure, anytime more than 90 mm of HT is an alert. Temperature monitoring less than 35 and more than 37.5 is an alert. And urine is monitored every 4th hourly or whenever the patient voids for protein and acetone. Coming to section 5 is for labor progress, which contains contraction, the duration of contraction, cervical dilatation, and the descent of the fetal head. So labor care guide does not contain intensity. That is something which is subjective, which is present in the modified partogram, but is not present in the WHO labor care guide. Contractions of less than 2 contractions and duration of less than 20 seconds is considered to be inadequate, and we will have to take appropriate measures, and we will have to augment labor, example with starting oxytocin, and any contractions of more than 5 and to a duration of more than 60 is considered to be hyperstimulus, and we will have to stop oxytocin and to monitor labor vigilantly. Coming to cervical dilatation plotted on X and descent of the fetal head plotted on O. Descent of fetal head is the abdominal route of measurement where we use the Crichton's method to find out the descent of the fetal head by how many fifth palpable the fetal head is. Coming to section 6. Section 6 is indicative of the medications that is used during the time of labor. That includes oxytocin, any other medications which is available, and IV fluids which is provided for the patient. So oxytocin, we start 5 units in 500 ml of IV fluids, and the drip rate of oxytocin is monitored. Medications include any dilators which is given for the progress of labor, and IV fluids for the oral hydration if the patient is unable to orally take fluids. Section 7 includes shared decision making, which is a newer component labor care guide, which includes assessment and plan with consideration of the alert column, and also to take decisions along with the maternal, while talking to the maternal mother as well as the maternal companion. And also labor care guide provides a section for second stage monitoring, which monitors the supportive unit care component. The fetal monitoring is done, maternal monitoring is done, and also during the time when the patient is fully dilated, and when the patient is bearing down, it is represented as a capital P which shows pushing. This is about the labor care guide and the 7 sections of the labor care guide.
Kalyani, can you please tell us about the labor care guide which you have plotted for yesterday delivered patient?
Yes, ma'am. Here is Mrs. K, 30-year-old female with primary gravida with 39 weeks period of gestation with JDM on OHA. She was admitted on 16th of July and was planned for cervical balloon catheterization. Next day morning at 17th July, 5 a.m., she was complaining of labor pain and hence was reassessed. Mrs. K, parity was 0. She was induced with cervical balloon catheterization. She was in active phase at 5 a.m. of 17th of July, and the rupture of membrane occurred at 9 a.m. of 17th of July, and risk factor for her was GDM or OHA. She didn't have a companion at 5 a.m. and hence it was written as N, that is no companion, and hence it was encircled as it is alert. And pain relief was given for her, which was injection tramadol. She was adequately hydrated with oral fluids, and hence yes was marked. And the posture was, she was in left lateral position, and hence MO, that is mobile, was marked. Coming to baseline FHR, she had the FHR range was 134, and there was no deceleration, and hence N was marked. Membranes were intact, hence I was marked. And the maternal pulse was 80 beats per minute, and the BP was 110 by 160 beats per 110 by 80 mmHg. Temperature was 37.2, which was febrile. And before reassessment, she was told to void urine, and the urine was assessed during dipstick method, and there was no protein or acetone was assessed. And cervical dilation at 5 a.m. was 5 centimeters dilated, and hence X was marked at 5 centimeter dilation. Descent was head was 4 by 5th palpable, and hence O was marked at 4. Coming to medication, sorry ma'am. Contractions, she was getting 2 contractions, each lasting for 25 seconds, and hence here 2 was marked, and here 25 seconds was marked. Oxytocin, she was started on oxytocin, 5 units and 500 ml RL with a dilution of 4 drops per minute.
Tramadol is at 5 a.m.
Tramadol was
It is
given
at
at
4,
5
so it's not marked at 5 a.m.
5
It is at 4
yes,
a.m.
ma'am. And assessment, she was told to provide with a companion, and the plan was to provide her with a companion so that her labor progress would be good. And every hourly support assessment was given, supportive care assessment was marked, and every half an hourly FSR was monitored and contractions were monitored, and oxytocin was titrated accordingly, and every fourth hourly reassessment was done. Reassessment was done at 9 a.m. That time companion was present, so Y was marked. Pain relief, she had given pain relief, so Y was marked. And she was adequately hydrated, so Y was marked. And posture, she was in left lateral position, so mobile was marked. Coming to fetal heart rate, it was 140 beats per minute, and there was no deceleration, hence N was marked. And their amniotic fluid, rupture of membrane occurred at 9 a.m. and hence C, which is clear amniotic fluid, was marked. Fetal position was occipital posterior and hence alert was marked, which was encircled. Coming to maternal pulse, it was vitally stable, and cervical dilation at this point was 6 centimeters dilated, and head was 3 by 5 palpable. Oxytocin was at 24 drops per minute. At this point, cervical, combined spinal epidural analgesia was given for her. Assessment was done. The posture was in alert line. The position of the fetus was in alert line, and hence she was made to give adequate analgesia and was monitored. Close monitoring was done. Next, she was reassessed at 1 p.m. Companion was present at that time. Pain relief was given. Or she was adequately hydrated, and she was mobile. Membranes were clear. Clear amniotic fluid was there, and the position of the fetus now was occipito anterior, and hence A was marked. Caput was present, which was +1, which is mild caput, and hence alert was not marked. Molding was +1, and that was also not marked as alert because +3 molding is considered as alert. Maternal vitals were stable. Cervix uterine contractions were 4 contractions, each lasting for 50 seconds. Uterine cervix dilation was 10 centimeter dilation, and hence here 10 centimeter was marked, and the descent of the fetal head was 0. Per abdomen, it was not palpable, ma'am. Oxytocin at this point was 40 drops per minute. Epidural top-up was given. She was we started plotting in the second stage of labor. In second stage of labor, every half an hourly it was monitored. Here companion was present. She was in supine position as she was not able to tolerate pain, and hence alert was put. She had started to bear down, ma'am, and hence pushing was marked here. And here the descent was taken. Cervical spine was taken as the position for monitoring, marking of the descent in the second stage of labor, and hence it is marked accordingly here. Oxytocin was at 40 drops per minute, and here she was encouraged to bear down. Next,
would you want to have a comment on the FHR also? Did you notice any variable deceleration?
Yeah. At 2 o'clock. At 2 o'clock, she had early deceleration, ma'am. Her FHR was 118 beats per minute. Early deceleration was there, but that was not alert, and hence it was not marked. That time, her descent was at 0, and the oxytocin was at 40 drops per minute. At 2:30, she delivered.
Okay. Thank you, Kalyani. That was very nice of you to explain the labor care guide clearly.
Dr. Akshita, can you tell me some pros about the labor care guide?
Ma'am, labor care guide, it is an evidence-based, and it looks to promote, give respectful, supportive, and high-quality maternity care. And it looks at providing positive childbirth experience with timely intervention and
However, the labor care guide also has some cons, such as it needs continuous ongoing educational support, and it creates a time and space constraint for the user. Thank you.
I would like to conclude by saying that Labor Care Guide is a new tool. It's a healthcare professional tool which is introduced for a better maternity care, for providing a respectful maternity care, and which is women-centric and also focuses on a positive pregnancy care.
Thank you, Dr. Punya. And also we take this as an opportunity to thank Foxy ICOG for this interactive session. We were a part of it and we are very thankful for this. Thank you.
Now, may we please request Dr. C. Nirmala Madam to give a valuable feedback.
And Dr. Jyoti as well, if Dr. C. Nirmala is.
I felt this was the
Madam.
second thing. There was some problem with the video and the thing.
Yeah,
It would have been
yes.
better if the partner, the graph would have been much focused with the student standing next to the thing, whole panoramic view. The same thing they could have depicted differently.
Yeah, there should be one thing is there should be clarity. One thing is screen is not focused. That those are the comments here. So when we send the recorded things, no, so we should edit it and send it. But overall, the feedback from Dr. Nirmala is also expected here. Yes.
Yeah, actually, I thank Foxy ICOG for making me as a part of this on this teaching learning methods, new technologies as per the CBMA. Actually, all the presentations were really good,
Yeah,
and they
very
are
good.
keeping the standards of the new teaching learning method. And as far as this last labor care guide is concerned, actually the whole concept of teaching method they have already internalized and presented, because the teacher was a facilitator and most of the roles was being done by the students. The onus is on them, and that concept is actually clearly shown here. Most of the time the teacher doesn't intervene, they just ask, they start the discussion, and the rest is being continued. And that's the whole idea of student focused learning method has been shown here. That way, except for the other things regarding the problem based or practical skill based care, it was an excellent presentation, excellent demonstration of the teaching learning method. All the best for all the students and teachers. Thank you.
Thank you. Thank you. So you make your all students to join this, all the Odyssey of teachers. So we are bringing out new methodology and how to teach and how to take best out of the students. And it is as the student focus, they are also learning and they are also teaching. All those things definitely is going to add to our knowledge. So thank you, Dr. Nirmala. In spite of so many hurdles, you could join, and Dr. Jyoti and her
Thank you,
team,
madam.
MS Ramaya.
Thank you, madam.
Yes. So I think, Vandana, we need to end here. And I really thank all the delegates and all the students and the demonstrators. So shall I give the vote of thanks?
Yes, madam.
Okay, so this webinar is really possible because of contribution of so many people. Not only one, but so many people are here. Right from I start from the end, that is the recording team and the IT team. I must thank that they did a very good job. And I thank our main convener, that is Dr. Ashok Kumar, and our ICOG team, Dr. Parag Binimale, Dr. Sheila Mane, Dr. Sarita Agarwal, and others. And the module of this is the second module, I must say. And always the ICOG office bearers and Foxy supports us wholeheartedly, and really I owe my utmost gratitude to all our esteemed faculty from all over India. Professor Padmaja Saman, Professor Amita Pandey, Professor Girija Bag, Professor Jyoti, who have worked, and Dr. Professor Nirmala also, who have worked very hard for past 2 months along with their faculty members and postgraduate students for recording these videos. Professor Arup, Yeah. Roop Mazi, as well as Dr. Professor Sangeeta Rai, Professor P.K. Saha, they have always be with us, and they have given their valuable feedback on the session. And last but not the least, I thank you for your backend team. That is, I have given the backend team first. Backend team is really very much strong support for us always. I must thank Dr. Vandana Agarwal. Actually, she is the main backbone of all the programs. She communicates and she brings out the best out of all. And I am very much thankful to Dr. Vandana Agarwal. And I hope we will leave today with the enriched experience, and incorporate this teaching methodology in your practice, means in practice of your teaching methodology. It should be always an interactive teaching methods in our day-to-day practice. We have got ATCOM modules. NMC has introduced many modules, and all teachers have to go for rigorous basic courses also. That is compulsory, they have made. And even the formulating the MCQs, the question papers, then we have to checking, all those methodology have changed. So let us be with these teaching methodology and let us get expertise. So thank you very much. The comments in the chat box, is it possible to go through the topics once again? If
Dr. Vidya Madam, I want to thank my co-professor, Dr. Sujini PK. She has been behind us and she has helped both Dr. Urvashi and Dr.
No, that
Gayatri.
is a team, MS Ramaiya. We are not individually,
So
we
her
don't
name
know the
was
names.
not mentioned. I thought I will let you know that Dr.
No,
Sujini.
that was not mentioned in that group, na. So you have handed over. You were busy, I think, for the recording. So they have recorded, but they have recorded excellently. Only thing is that projection and
the
things
projection.
were not visible to all, but it is okay. We are just telling them. We are not teaching them, but how to teach that topic. We are explaining like how we can teach. This is one of the methods.
They will know better and better next time. They will do.
No, when they are teaching their student, definitely they will correct this, that it is visible. So that feedback we can take it as a positive comment. Okay. So thank you very much. Thank you very much. Thank you, Vandana.
Thank you, ma'am.
Again. She is better half of mine. Yes.
Yeah, she's too good. Too much.
Thank you very much. Thank you all. Let us meet again in the next session. Okay.
Recording
And I also thank Dr. Sheila Mane. She is always there for all the programs.
Thank you.
Yeah.
Thank you, Vidya.
Yes. Thank you very much.
Thank you.
I have done maternal death review in between inspection of
I could not join that. I could not join that maternal death review, but I'll definitely make
and then inspection also.
Madam is multitasking always.
I know what to do, yeah. Anyway, chalo. Good. Good job, Jyoti.
The capable people only will be given responsibilities like this. Yes. Thank you.
Whatever is God's wish.
Yeah.
Yes.
Thank you very much. Thank you.
Madam. Stop the recording. Thank you. Bye-bye.
Thank you. Thank you.